So, Ahman Grayson, let's see, I've been in EMS for approximately 15 years. I took my EMT back in 1999. I've been a medic now for about 8 years. I've been a firefighter for about a little over 11 and a half years or so now. So, and I got asked to speak to you guys just about the pre-hospital setting, what our job is as far as related to trauma, and for paramedics, EMTs, things of that nature. So I'm going to go over some real basic stuff. Just most of it's straight out of the county protocol book that we use, and then I'll have one case study. If you guys want, we could talk about other stuff. I'm very flexible, so I heard you guys had a lot of questions earlier about some pediatrics, and so maybe I'll help answer some of those questions for you guys. These are my objectives for the day. So just to help you guys understand the criteria we use to identify a trauma patient out in the field for the adult and the pediatric, and then what type of protocols we use to treat them. So first go over this, identification of a trauma patient, very basic. And for trauma, these protocols aren't necessarily a major trauma. And so those are our major traumas, or the traumas we're bringing to you guys to the trauma center. This trauma protocols encompass all traumas. So from minor cuts to broken legs, broken arms. So it's all encompassing. So the stuff that you guys see is on the higher end of the spectrum of what we deal with. So Stephanie passed out a trauma algorithm to you guys. And that's straight out of the county protocol. That's what we use to as a flow chart to figure out what would be considered a major trauma for patients that we bring to you guys. So the first portion of that is your physiological criteria. So anything less, Glasgow Coma scale less than 14, any abnormal vital signs. As far as the vital signs, they're pretty basic. So anything BP less than 90, heart rate greater than 150, respirations less than 10 or greater than 29. So some pretty just broad abnormal vital signs. Obviously the appearance of the patient, worker breathing, and just obviously circulation, so if they're bleeding, things of that nature. So next level of that is significant anatomical injury. So that anatomical injury could be broken leg, broken arm, both broken legs, whatever, eviscerations, any kind of major anatomical issues from some kind of event. Mechanism, this is one of, I think, probably the more subjective portions of trauma, and it's very hard to sometimes determine on scene, where you get different stories from these people, you get different stories from this people, or nobody knew or saw anything, and so you're trying to decipher what exactly happened to our patient. So sometimes it's very obvious, sometimes it's not. We're going to go over the trauma tree, the algorithm. I know it's not the best up here to look at, but just kind of from the top down. Have you guys looked at that? Any questions just off of that real quick? We'll go over a couple of those things, but I'm going to hit a couple highlights. But anything major, is that pretty self-explanatory?
Is blood thinner on here?
Oh yeah, it's at the bottom. So that, yeah, and we'll get to that. So as you can see, the top is just the basic vital signs. In the first two sections here, they're pretty obvious. You know, if you have some obvious anatomical deformity, we're going to be bringing them to you guys. So, the second is mostly dealing with mechanism of injury, whether usually it's traffic accidents of some kind. So those are pretty obvious. If someone's dead in the same compartment, or ejection, or things of that nature. Falls three times the patient's height or 15 feet or greater. Sometimes it's a little harder to determine because you're just guessing for the most part. But if you have any indication of any of these two, they're going to. The ones that you guys are going to see that you're probably going to question the most is going to be from this last big box here, and those are just I guess you would call it, between the paramedic and the MICN, they're kind of their intuition. Those are the areas where there's a lot of gray area as far as our patients go. So the bigger one, as you stated, was the anticoagulants. So, you know, greater than 65 years old and they have a fall and they're on Coumadin, technically, they have to be a trauma. And so, and it's a judgment call on the medics in the medic's place as far as how the fall is. Did they fall from the bed down to the floor? Did they fall? And then also, it's also dependent upon the MICN. So when we call in and we say, hey, I have a 70-year-old male who fell off the bed, you know, if we don't give up the information that they're on anticoagulants, they'll usually ask, and then they'll want either a better story. Was it witnessed? How big of a fall was it? There's a lot of other questions that go along with that. So that's why sometimes you guys will get them in your unit and you'll be like, I don't understand why they're even here. So, and we do the same thing. And it's part of the protocol, and it's kind of what we're guided by. So there is some leeway there. There are some times we can, but not very much. So, especially, I would say for older medics that have a little bit more experience like myself, we can kind of help ourselves with doing some of the stuff. Not so much just telling what the MICN exactly what happened, painting a really good picture for the MICN, saying, you know, not just saying, hey, I got a 70-year-old male who fell, who's on anticoagulants. You know, you basically say, you know, it was a 70-year-old male, slipped, slid off the bed, was witnessed, had a very soft landing. You know, yes, he's on blood thinners. He has been for a long time. There's no indication. You know, there's a lot of things you could say to kind of help not make the patient a trauma patient. More than likely, they're still going to go to a trauma facility, but whether or not they're actually going to be bringing them to your unit is another story. So, the other big one on there is the paramedic intuition. So, and you have to, as I'm sure you guys all understand, that all of these calls are extremely dynamic. So what we see and then what we bring to you and what you see can be completely different. And you know, that kind of, it's hard. So especially with newer medics, I'm sure you guys get a lot of patients who have no idea why we're getting them. And then with some of the older medics who you may see, why didn't you make this a trauma? And you know, so it's a give and take. So, and then at the very bottom, when in doubt, just take them to the appropriate trauma facility. And we do that all the time. Technically, we don't do trauma resources anymore. Are you guys familiar with that at all? So back, I guess they stopped doing this a few years back, but where we would, on these questionable calls, we would call it a trauma resource. So we call the MIC and say, hey, I'm not really sure what happened with this patient. Give them a quick rundown. What do you think? And they say, you know what, just bring them to us, and then we'll help make the determination after the fact. That will be considered a trauma resource, where there was some incident, but we just couldn't really determine whether or not it's going to be a major trauma, warrant calling in the trauma team or anything like that. So, so usually we'll just bring them to the ER. They'll help make a determination from that point, and that may be why sometimes you guys get patients coming directly from the ER that were transported by us from the ER transferred up to your unit. So technically, per our protocols, that doesn't happen anymore. It's either yes, they're trauma, no, they're not, but there's still some wiggle room there, because if we just bring them here to UCSD and you guys decide the nurses decide they want to make them a trauma after that, you know, that's not our call to make. So, but we try to do the best we can getting them to the appropriate facilities so you guys can make that determination on your own. So.
But they're also taking other calls too. They're multitasking. It's not just the trauma. They're triaging every ambulance that comes through the ED. So I think that's an issue with the MICN.
Oh yeah,
it's not the.
I think our MICN needs investigation.
Yeah, but I'm just saying, I think that sometimes they drop the ball, or the medics notify them, and they may have a 5-minute ETA, but they're triaging other ambulances that come in. So by the time we get the call, it's 2 minutes, and they're really at the back door.
Yeah, so to kind of touch the base on the radio system, the way it works. I'm not exactly, I can't remember off the top of my head how many actual base hospitals are in the county. I want to say there's like 12, but they run every single patient, every call that goes, or every patient that goes by ambulance into an ER, these MICNs are running. And so from multiple agencies, multiple places, and so they're inundated. And the way that we'll kind of go over a little bit of my radio report, they're not short. So they want a lot of information, you know. So, and that's for every single patient. So not only patients we're bringing to the ER, but patients we're AMAing, And so it's a lot to have to deal with one MICN for, I want to say UCSD has probably 50 different units that they are responsible for. So what the base hospitals do is they split up per agency and units how many people they are there. We have assignments. So like if I was out in the field and I was down at Engine 29, Engine 29 has their base hospital is here, is UCSD. So we have to call here, and so they get assigned there. But it always happens where UCSD is busy. We got to call Sharp, or we got to call Grossmont, or we have to call. So we kind of shop around to get what we need so we can further the call. But it's the system is busy calling on the radio. So that could also contribute to how long it takes for them to actually get on the phone and talk to you guys. Yeah, so typically, and this is, I don't know when this changed. When I got trained as an EMT and as a medic, typically, if you were going to get a major trauma, you call the facility that you're going to be going to. So if I'm bringing you guys a patient, I call UCSD and let them know, hey, this is what I have. So that the telephone issue is shortened. So at least they understand exactly what we're bringing you guys. But now I think with how busy they are, and I don't know if it's due to medics wanting to get off scene faster and quicker and get to the hospital, or if there's just more calls in general that they're running, you'll have a lot of people calling other base hospitals and relaying that information to the transporting base hospital. And then even that, they're losing a lot of information, they're losing a lot of time. So that's, I would say in the last 4 or 5 years, you're gonna see a lot, it's been a lot more of that. So.
Do we need more MICNs?
No, I don't necessarily think more MICNs would work. I think a different, they've gone through a lot of iterations and changes, and they try to shorten our radio reports. They've tried to do this, and they've tried to, give us more standing orders out in the field so we don't have to make communication. And that's something that the county, that's something that it's their system, and that's something that we're just kind of working within. We work with them, all the MICN coordinators, base hospital coordinators, our EMS division, they work with them on a consistent basis, but it's a hard thing to change. So it's been like this for a long time, and with just the population increase and everything else, how many calls we're running. I mean, the city of San Diego, we run 180,000 calls a year, and 90% of those are medical. So, and we're the biggest agency in the county. So, I mean, you can extrapolate that out to how many different calls throughout the county that we're getting. And so, we have, it's busy out there. So, yeah.
I have a question about when we get a trauma now. How does that, so is that an issue with the MICN not calling us because it's like a short time? Because you guys always call the MICN and tell them they have trauma. How they happen? Yeah,
and so and you have to take into consideration too. It's case specific. There could be a traffic accident right here on Washington and 4th. That's a major trauma, and depending upon the nature of the call, we may not even be able to get a hold of the MICN to let them know that we're here, and we could be downstairs walking up the stairs and they'll call you guys like, you guys got a trauma and they're here, so it's a very extremely dynamic scenes, so depending on the call, there's so many factors, it's hard to really kind of pinpoint one specific reason why the time gap from you guys getting the call and us showing up, it's so many different factors, traffic, patients, it's too many to really factor in. So
you guys have to sit and wait and call different hospitals because UCSD is busy?
No, we don't. And we have written in our protocols communication failure, and basically depending upon how many times you attempt to call, we have, along with the communication failures, they've upped our standing orders, so orders that we're allowed to give on our own and treatments we're allowed to do on our own. So if normally some of those orders we have to get from a base hospital nurse or a base hospital physician. In the event of a communication failure, our standing orders get increased. And then we are still allowed to bring patients to the hospital even without calling. So that could happen, and that is the frequency of that has increased significantly in the last few years because of how busy they are. And because, you know, some hospitals are better at taking calls than others, you know.
Who's better at it?
To be quite honest with you, Mercy is very good, very, very good. And they've known to be very good. Yeah, their MICNs are very good. They're able to take multiple calls. And by 2, 3, 4 calls at a time, and being able to
So you feel
work.
our MICN had a little more education?
No, not necessarily. No, not necessarily. No.
Beat up on the MICN, but it's very frustrating the lack of communication we have.
And I can see that. So yeah, and I think to be quite honest with you, Mercy has just been doing it a lot longer. They've been doing, those nurses have been in there. Some of those nurses have been doing MICN for 20 plus years, and they understand how to do it. They understand what's serious. They understand what keywords to say and what to really key into and listen to. They're just, you know, Scripps Ahoy is the same way. They do very well, you know, with that.
Question. I mean, when we get a call that our MICN says is a Mercy call, we get like absolutely no information. Is there a difference between what Mercy wants from you guys, or the information?
No, the information's the same countywide. How that information gets relayed back to you guys, we have no control over, so we don't know. Yeah.
Do you have a reputation in the community? I mean,
no. Your reputation is, yeah, your reputation is good. Your reputation is very good in the community. So. I don't know. Do you guys? I don't know. You guys weren't providing that anymore. You were at one point. You were. So, but no, the reputation is UCSD as far as MICNs go is good. It's better. But you guys also have to realize that it's only been in-house for what, 4 years now?
Oh, but it used to be in-house before.
It used to be in-house before, and for a long time it wasn't. And so when it was over at AMR, they were getting, most of those nurses that worked over at AMR actually worked at Mercy. And so, and so they were working overtime at AMR when you guys were doing it over there, and then also working full-time at Mercy. And so, so yeah, once you guys brought it back in-house in the last 4 years, it's the learning curve. At first it was tough. It's gotten a lot better.
But do you think it's because we do our trauma patients outside the ED also, so those nurses that are commanding those?
Potentially, yeah, and that's not, it's hard for me to say because yeah, I don't know. Yeah, I mean that you guys are very unique in the way you run your trauma system. That's not bad or good or in any way. Yeah, it's different, and so I know that it seems the relationship with the nurses at other places and the trauma nurses are a little bit better because, and the only reason why I say no is because I'm married to one, but in the ER when they're working together, it seems like there's a little less issues with that. And I don't know if it's because you guys physically have your units separated. I don't know. I can't say one way or the other.
The MICN don't do trauma the way we do it, and they're not used to it.
I'm sorry?
The MICN here don't do trauma like they don't upstairs with that, so it's run totally differently, and they're not used to the system.
Yeah, it could be. I mean, I know for us, when for a long time, the MICNs weren't enforcing ride-alongs with us out in the field. And once they started enforcing that they have to do ride-alongs, that helped our relationship out tremendously. I can't, one specific nurse that I worked with here, actually at this hospital, she worked here for a long time in the ER, and she came and she did a ride-along with an ambulance, and I was on an engine. We did a call. It was for a seizure call, just a basic normal seizure call. Patient was still seizing. We got on scene. We did our thing. Within, I don't know, 7 or 8 minutes, got the patient on board, loaded up, ready to go to the hospital. I went to the hospital, and afterwards she was really taken back by how much stuff we actually did on scene and what we got accomplished in a very short period of time. And then on top of that, getting them to the hospital and bringing them. So it's something that she had never even realized and even thought about what we actually do as far as, you know, vitals, IVs, meds, getting on the radio, packaging. Probably the biggest thing is extricating the patient. You know, that's very, I wouldn't say misunderstood, but it's not really taken into account how long it takes and what we have to do to get patients from point A to point B, because usually the patient who needs to have an elevator doesn't have an elevator, and so we have to get them from the 4th floor all the way to the ambulance, without, with them on breathing machines and IVs, and so there's that aspect of it. So, but yeah, the relationship definitely, I don't think it would hurt to have you guys work a little bit closer together, whether that they come in to the trauma room and see what you guys do in the trauma room and vice versa. I don't see how it would hurt. So
the offer is already out there, and that's something Jonathan has been responsible for facilitating. So I think if we can having the MICNs come and visit us in the trauma bay and vice versa is something that is on Jonathan's table, which he's done it, maybe not consistently, but I think as far as MICN's questions, Melody would probably be the person that we can pull together and have that discussion.
Any other questions about that? You guys good? Okay, perfect. We'll move on. So, self-explanatory. So this is the one that you guys might have more questions on. So this is actually written into our protocol manual. So I don't know if there was a specific incident that happened. I'm not exactly sure. But basically, and this happens more often than people really realize, that where we would have an adult trauma patient along with a pediatric trauma patient and transporting those patients to the facility, whether they're relatives, family, and they either want to go to the same facility and or they need to go to a trauma facility. 9 times out of 10, these patients go to Sharp and Children's. Just because of the close proximity of Children's to Sharp, that normally happens. That being said, extenuating circumstances and other circumstances, I'm sure you guys get a lot of adult plus pediatric patients brought to you, because technically you guys are the backup pediatric center. And so you're the only one in the county, and so I'm sure you guys, and obviously you deal with adults, so you guys are gonna get both. How often is that happening to you guys?
Not very often.
No? So?
3 to 5 a year.
Yeah.
Okay. All right. So, and then along with that, may help with, I don't know, getting pediatric patients. There should be going to Children's. I heard Dr. Potenza talking about the last call that he was, the fire, he was talking about the 2 ladies and why they went to Scripps La Jolla and Sharp. If there was any airway issues or anything like that, they may be closer to here, so they may stop here first, and then whether or not they say, you know what, we're going to bring them up to the trauma room from that reason. So there's a lot of other issues that could potentially get you guys some pediatric patients or patients who you guys would not normally see. So here's a question for you guys. How many, do any of you guys know how many base hospitals or trauma centers we have? I'm sorry, trauma centers we have here in the county? Yeah, there's 6. There's 6. Most people forget Children's. It's not on there. Children's encompasses the whole county. So there's 6. So you guys' trauma catchment is pretty much, South Coastal area, the 5, anything west of the 5, up through, I want to say Mission Bay area. So you guys are going to see a lot more drownings. You guys are going to see a lot more water-based stuff, just geographically wise, versus Mercy sees a lot more GSWs and things like that because of their geographical area. Obviously, Scripps La Jolla's got a lot more of the coast than you guys do. Palomar sees a lot more ATV accidents, things like that happen out east. So we're going to kind of dive into our treatment protocols. So this is, like I said, straight out of the county protocol. All of our county protocols are BLS side and an ALS side. So they go well for all of our EMTs out there who are on BLS units and or working with us on ALS and all their protocols. And then on the other side, on the ALS side, is all the things that we as paramedics can do. So these are just the basic things that we do on scene of all different types of traumas. So it's always BLS to ALS, or at least we try to make it that way. So, so we kind of highlighted the fluid bolus and to maintain the BP at 80. This is new, the 80. I think they changed it 2 years ago. It used to be 100 when I first started, and then it went to 90, and now it's at 80. And so, and I think that's just because of how dynamic blood pressures can be on scene, who's taking them, how they're taking them, how the patient's positioned. There's a lot of other factors that go into that. So we try to we do a lot of manual BPs. We found that a lot of the automatic ones with the time and that we have there just don't work. You know, they take a long time to cycle through, long time. And if we need to give meds or anything else, so you're going to get a lot of manual BPs. And then on top of that, the environment, it's loud, it's bumpy, there's a lot going on. So, so that's why I think 80 is a good number, just because of, we just basically want them to have some kind of blood pressure. So, and we don't want to fill them up too much. So. The pain protocol for you guys, like I said, this is just a general trauma. Obviously, if there's a multi-system accident, you know, we're not giving them any pain meds whatsoever. But if it's an isolated, like arm fracture, you know, we're allowed to give pain meds. Let's see. So this is kind of going into our treatment, so more specialized treatment. So for a major trauma, we would do what they would call a killer survey. So killer survey would be to check the head, chest, abdominal area for anything that's basically going to kill the patient. So that's where all of these treatments kind of come into play. So if we find one of those issues, we stop, we fix it, and move on to the next. These are some more treatments for some of our specialized patients, impaled objects. The BHPO is base hospital physician order. They were allowed to remove impaled objects unless they're, obviously the exception is if there's an airway issue. So ABCs are our first line of assessment every single time. When you see us teaching newer medics and newer EMTs, we always hit home ABCs, 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 and you'd be surprised how much guys are like, well, did you reassess, reassess, reassess? So it happens consistently, over and over and over. So.
Ahman, what do you guys do now? Like, do you do RSI?
Oh no, RSI has been gone for a long time. Yeah, so it depends on how the airway issue was to come about. So if it's a traumatic, and it depends on the situation. So if we're talking they're resting in their home from some issue, then yeah, we intubate. We don't have any. We can sedate. The only sedation drug we have is Versed, but that is a variation for us. We don't use it for that. So they have to basically have no gag reflexes. They have to pretty much be completely unconscious before we can intubate the patient. So yeah, we have that as far as airway goes. We have that ability. Actually, we're very good at it, and at intubating patients. But then also we have not combi tubes, but we have combi tube type airways. We have other airways, but depending upon the call, you know, we have the advanced airway, the intermediate, and then bagging if we need to. So, cool. Yeah.
The last thing, blunt traumatic arrest.
Yes.
That's a question, you know, you make a blunt trauma that's in arrest, so no RVs. That's always kind of been a question of ours.
Mm-hmm.
Do you actually start CPR and everything? If you come across a person who looks dead and kind of is dead and doesn't have any pulse or anything, will you go ahead? Do you start CPR on them, or yeah?
Okay, so it's a good question. If it's one patient, and it depends on the situation. It depends on the medic. It depends on everything. But if it's one patient in the middle of the street, nobody's around, nobody knows, probably, you know, you're probably going to do some BLS CPR until we figure out what's going on. If there is an obvious mechanism that this kid got hit by a car and got thrown 60 feet in the air and he's down, and then probably not. So we're supposed to do some kind of treatment until we get an order, but sometimes we may not have the time. If it's a multiple patient incident where there's multiple people, then we just triage them out, and that's just kind of the way it goes. And so we may get back to them, and we may be able to do some work on them after the fact, but if they're basically not survivable, then we move on to the next patient. And so.
Are you allowed to pronounce people at the scene?
Oh yeah, yeah. If there's an obvious sign, of death, and we use the DRIDE acronym, which is let me see if I can remember: decomposition, vigor, evisceration, a couple other things. Then yeah, we're allowed to basically call them right off the bat. If they have, in this instance, if it's a traumatic arrest, they obviously have some kind of life sign of some kind, and so we'll usually work them a little bit, but it's just no extenuating measures. It'll be bagging, CPR, till we get the doctor on the radio, let them know what happened, and then usually we call the patient right then and there. So.
If it's a blunt trauma, because we used to have, remember in our protocol, it was like if it's a blunt trauma and there was a sign of life, even one, then we would take them to our resus. If there was never a sign of life, we brought them to the resus room and usually.
I know,
That's
what
still,
we
so
did.
if they get to us, can we assume that you saw a sign of life somewhere?
Yeah, and that's another, and then, you know, that's the other side of it. You know, the intuition and the experience, all that stuff really plays into it. Because as a brand new medic, if I were to get on scene, even with this protocol, and I had a traumatic arrest, you know, a blunt traumatic arrest, and I didn't feel comfortable calling the patient right then and there, I'm gonna bring the patient to you guys and let you guys do the work and let you guys call him. And that's within my right as a paramedic to do that, you know. And so it's hard to, as you guys all know, it's hard to teach those intangibles to people. You know, it's hard to teach people to take a step back and say, you know, this patient isn't going to make it. You know, it's really hard to do that. So it takes some time to learn. It sounds like, to me, just based on the information you gave me, it sounds like there's an inexperience on two people, the medic and the MICN.
Well, yeah, because versus it only is called Peds versus Auto, like a will.
That's on something like that, there's a couple different factors that go in that, but if you technically pronounce at scene, because we can't.
You as paramedic?
No, not on something like that. Like if it's only unless it meets that criteria, like it's a decomposition rigor, if it's one of those of obvious signs of death, we can't. We have to call it in, and then the doctor is the one that does the pronouncing. So we can't.
You can pronounce over the phone?
Yeah.
Okay.
Yeah, but it's based upon the information that we give them. So if on that call they said, you know, there was, and doctors are very reluctant to pronounce children in the field. I can't. In the 15 years I've been doing this, I've had maybe 2 doctors pronounce kids in the field. 2 out of, I don't know, the hundreds of CPRs we run. So they're very reluctant to call kids in the field just because of their resilience. But it seems like the ball was dropped at some point. So the doctor should have called the patient. And there's another part of that. If he was technically pronounced on scene or en route.
Pronounced by MD.
Yeah.
And then they started.
So here's another issue. So with that, if he was pronounced en route to the hospital in the back of the ambulance, there's an issue, and this is a totally separate side of it. There's an issue with, depending upon who the company or who the transporting unit is if the patient was actually pronounced in the hospital or in the ambulance, the coroner has to come, and the ambulance is out of service for an extended period of time. So depending upon that, their interagency protocols, they may not want to ever pronounce a patient inside of an ambulance so they can get that ambulance back in service. And so that could have been a reason or a part of that.
I don't know.
Yeah.
Before you said pronounced at scene.
Yeah, if they were pronounced at scene, they should leave them there.
They put them in the rig and then brought them to us.
It sounds like something either got dropped, somebody's inexperienced, someone got scared. Yeah, they call them and left. If it was me, I would have called them. You know, had the doc, called the doc, did my radio report, gave them what they needed to know, and you know, dealt with it there at the scene. But yeah.
One more question.
Sure.
No, you know, so we have trauma patients that are made of major trauma, but then I'm not criticizing. I'm asking, they're not in full spine, they're not in spine precautions. So I was wondering how they're made of major. You know what I mean?
It depends on the injury. So it depends on. Not every major trauma patient that we have necessarily needs to be C-spine. And so, yeah.
So if it's a fall or a found down, you guys can make that determination?
I wouldn't say we can make the determination. If it's a fall, and you know, if it's a fall or a man down, 9 times out of 10 you're going to find them C-spine. Unless there's some other indication that I would say 90% of the time they would be C-spine. If it's a GSW or some other issue that goes on there, they may not be C-spine.
Found down, or maybe after a seizure.
Yeah, and the whole found down and the whole man down it's a lot of going back to that human factor. It's a lot of that. It's a lot of, well, okay, where do we find him? You know, a lot of people don't take into the whole picture. Where are we? Is he a very high homeless population? Is it? There's a lot of issues, and yeah, I would say the newer paramedics, you hone in to just what your patient is going, what you see. Yeah, technically, I have a man down. There's a man down, so there is a protocol that we go through. Okay, so why they're down, but they don't take into account. I'm responding downtown. There's 3 bottles of liquor over here, there's that over there, we're going into some bushes. Some of that information just doesn't get processed. Sure. Yeah.
Because I got some answers for you. Okay. Years ago, when in the early days of trauma, everybody was in supplying precautions. Yeah. Then when I got over there was happening, when we do the next day recess flow sheet, that is one of the things we're looking at. And I started firing the letters off to our base hospital coordinator. They came in and no response at all. Then I learned that it's a new gentler world, that when they're documenting on the run sheet, patient refused, or they document denies head, neck, or back pain, it's acceptable.
Yeah.
So that's what's happening. That's something to take up with our institution specifically. It's not the field.
Yeah, and like with most of you guys' questions, it's going to be very, very dynamic. So.
Spine on people that are difficult. The body habitus.
Yes, that happens also. So.
Yeah. So that counts. That's right.
Yeah, and sometimes they may forget to even tell you that they refuse. When we're trained, when we come to the trauma room facility, to be very short and direct with the nurses and the doctors, and sometimes it doesn't always happen, but we know you guys want to get to work. We know you guys have a lot going on, and you want to, a lot of times if you're not short and direct, you get pushed out of the way, and that's okay. It is what it is. So, but yeah, there's a lot of factors that go into that. So whether or not they C-spine, whether they don't, whether the patient refused, whether the patient was somewhat combative, and there was just no way we could get him into C-spine. Like it just. Who knows, so, all right. So these are a couple other here, so crush injuries, which you see very rarely, but these are the protocols we use for our crush injuries, and then also the needle thoracostomy. So those are far and few between, but they happen, and you guys will probably see them obviously a lot more than a single medic out in the field will, but that does happen quite often. So here's what I have a scenario for you guys. I have a case study that I want to kind of go over with you guys, but I would like to open it up to you. Does anybody have one that they've been dying to talk about and dying to ask, dying to discuss a reason why we do what we do or anything else? Did ever a situation, a call, or anything else come up that you guys maybe want some clarification on?
I don't, but
yeah.
I have one question. Do you guys, the paramedics that work for, in the catchment, UCSD's catchment, know the OR recess criteria, and like if you're kind of like thinking this guy looks pretty bad, do you like say, I know the criteria, so I'm going to say this? Is there a feeling about that? No. And usually what happens with OR recesses is usually a senior medic says, this patient's really messed up. He needs to be seen in the OR, and then that's a call that we make in the field, but we don't, there's no criteria out there, at least per our protocols, as far as OR recess. And so and to be quite honest with you, I don't know if there's a county protocol or county standard.
We make the call.
Yeah, and if that's because, and like you said, to train just the people in you guys' catchment, our medics are dynamic. Like in most of the area where I worked in the Southeast, we went across catchment areas all the time, all the time. So if the policy for you guys is different than the other hospitals, we wouldn't know that. And there is no county standard for OR recess. So if there should be, that would be nice, because then we'd all know. But that's not something that we can.
How do you know someone's coming? Well, when you pick someone up at the border, I mean, how does that work? Because
the border. Okay. Well, luckily I've worked at the border for a long time. But so the border is a whole nother monster. Okay. So the way that the border works, first and foremost, the border in and itself, as far as trauma is concerned, okay? If the patient has a requested facility, we have to bring them to the requested facility, okay? So there's that, there's...
If it's a trauma or not a trauma?
It doesn't matter. So...
but they've already gone through...
So, and that's, yeah, and because it doesn't, if they have a requested facility, we have to bring them to the requested facility. Is that even for trauma? Does that make sense? So if if they request, so let's say that they determine that the patient is a trauma and they are a Scripps patient, they can go to Mercy versus coming to you guys. So if that doesn't happen, then you guys alternate months. And that's how it goes. So basically, if the patient's unconscious or has no preference as to which hospital they want to go to, the trauma they rotate months. And I forget which one is which, but you guys rotate between Mercy and here for traumas. So.
How do they get through the border?
They're Americans, so they get through. So if they come by ambulance, they come by family, they come by friends. They get, yeah. Obviously, we don't go if they don't get through, but yeah.
But if you're not at the border, you have to go to your catchment area. How come somebody at the border has...
Because it's right in the middle of your catchment area. So the border is right between the 805 and the 5.
And what about when we have, again, for the border? Because if they have... Last time we had a case where the Border Patrol requested to come to a certain hospital because they have another one that they're bringing, so they don't have enough personnel to go to a different hospital. How can they do something like that?
Because then in a case like that, they're probably not here legally. So so that's a different story. So yeah, and then that's a call that Border Patrol needs to. That's a call that they get to make on. So because they're not U.S. citizens and they get injured or hurt on our side, we are bound to help them, but they're still in custody. And so without having, and basically at that point, Border Patrol is footing the bill. They're paying for these patients to get seen and treated. And so that's why they get to make the call whether or not they get to go to this facility or that. So that's the way that it runs with that. So
it doesn't matter what time of what month it is, it's where the Border Patrol people...
And those calls don't happen often. So I know you guys may see them a lot, but they don't, where they are not American citizens and they get injured to the point where they have to come to a trauma facility because they have to be on this side of the border for us to even get to that point. So usually what happens is they'll fall off the fence or they'll get hit with a rock, and it happens, but of those calls, they're very far and few between. And if they're in custody because they have a record or some other issue, then yeah, it's their call.
We used to get people to fill out the things and take them more. I don't feel like we get that.
Yeah, because now we're able to treat in the field with meds, and we can bring them to Sharp and Scripps, Chula. They get a ton of patients. They have to rotate every day instead of every month. So they get a ton of patients down there. So
how about the people that are not, they're not American and because I know we get sometimes that are like in car accidents in Mexico and they're not American and then they're in the Mexican hospital and then after a few days they get somehow transferred here. They're people at the border, so they just...
Yeah, so that is a whole nother, that's a paperwork nightmare. If that usually doesn't happen because to have them, there's a big paperwork petition that they have to make to be able to get over here for medically to get some kind of treatment. So sometimes, and I mean sometimes, they actually have it set up with the hospital that they're coming and that they're going to get transported to this facility for whatever reason, whether their doctor set it up or whatever. But sometimes they don't. And then what happens is they get to the border and then they're compelled to help them at that point. And then they have the Border Patrol or at the border, they do have medics and they have nurses, but they do not have the facility nor the infrastructure to help patients like that at all. So, and if they get to the border, which is hard in itself, then they're compelled to help them. So, and especially if they're in U.S. soil, then then they have to. There's nothing they can do about it. You can leave the lights on. Since we were you guys brought up the subject about the border, I'll have a little, firemen have a lot of stories, but I'll have a quick story I'll tell you guys about one of my real difficult calls and kind of give you an idea of what we experienced down at the border. So we get a call. I'm on an engine, on a fire engine, and there's 4 of us on there. So there's a captain, a driver, and 2 of us in the back. So we get a call for it's for an 8-year-old female stomach problems. I'm like, okay, cool. Meet them down at the border. At the border, they have a secondary checkpoint where they bring all the cars that they want to check for whatever reason. So they call that the secondary. So that's usually where we pick up most of our patients. So we roll up there, and there's a Mexican ambulance there. And so I open up the back door because I'm getting ready to get it on the medic there, and open up the back door, and all I see is an incubator and a doctor, and I'm like, what is going on? This is not an 8-year-old female with a stomach problem. So come to find out, it was a 3-month-old baby who had some GI/GU issues while they were in Mexico. The baby was an American citizen, and they went down to visit family down in Mexico. Had some issues, was at the hospital, got an infection while in the hospital, and they were having a really hard time getting the patient over across the border to Children's. So what the family ended up doing is basically, it was a CCT call. They had, normally it's just 2 Mexican paramedics, but this time they had 2 Mexican paramedics and a physician in the back. And so they basically brought her to the border, called 911, and then they wanted us to take her to Children's. The problem was a couple different things. So I'll start with yeah, that's fine. The medics and the doctor, neither one of them were a U.S. citizen. So I'm like, okay, that's an issue. So the second thing is the baby was actually very stable. There wasn't anything that we were going to do for the baby, but she was on a respirator. So none of our ambulances, they do now, but none of our ambulances have inverters. So it was in the back of, they had you guys know what an inverter is for electrical inverter? No. So most of the current that you use is AC and plugs, but in normal car batteries, they run DC current. So when they run so if you're gonna run any kind of household electric or any kind of, you need an inverter to convert that AC or the DC over to AC. So none of our ambulances at the time had an inverter. So the respirator, we couldn't plug in, and we couldn't take her off of the respirator. So the doctor basically said she detasks very fast. If you take her off the respirator, there's no way we can bag her from point A to point B. Okay, and then to add to that, she only has enough sedation for about 30 minutes. I'm like, oh, okay. So we're not trained to how to use respirators at all. That's not in our scope of practice. We don't, because there's so many different kinds out there, we don't, that's not a part of our protocols. So I had 2 choices. So basically, this is what I told my captain, is I was like, hey, we have 2 choices. We need to get this kid to Children's one way or another. We can either get call for Mercy Air, land a helicopter here, because flight nurses and flight medics have the scope of practice to be able to use respirators, and they have one. And get them here so they could take the patient, and or we get clearance through Border Patrol and we take this Mexican ambulance up to Children's Hospital with me riding in the back. And so he was like, okay, all right. So he goes over and he talks to the Border Patrol, and they okayed it. So they okayed having 3 non-citizens drive a Mexican ambulance with no United States insurance on the road to the hospital, all the way from basically the border up to Children's. It was in the evening, so there was very little traffic. There wasn't any issue with that. You know, it was obviously for the benefit of the patient, because we got her to the hospital, and then come to find this out maybe about 2 months afterwards, that she died from her injuries and from the infection. But you know, those are the type of calls that you get. They're just, and the border in itself is its own monster. They have so many weird and different kind of calls that happen down there. And so, but yeah, very specific to that call. This is going to be just a quick case study. This is probably something you guys see on a probably more regular than any other kind of traumas, traffic accidents. So our call from dispatch is going to be a rescue traffic accident. Real quick, the difference between a rescue traffic accident and a normal traffic accident is that we're getting a report that someone is trapped. Someone cannot get out of the car. And it doesn't necessarily mean it could just be anything. It could be that they just need to take their shoe off to get out of the vehicle, but they're unable to get out of the vehicle on their own. So that in and of itself, we need more resources for that. So this is not one of our accidents, but this is something we pulled off the internet to kind of give you guys an understanding of what happened. So in this call, the scenario we're going to run, we got a call as a multiple vehicle, but originally really only one vehicle. So this patient was driving eastbound on Palm Avenue and basically struck a telephone pole going approximately 45 miles an hour. Okay, so single vehicle, restrained driver. Patient is approximately 25-year-old female, and as you can see, this is a significant mechanism. So, and without going too in depth on the anatomy of an accident, most vehicles, this is a truck, this looks like a Toyota Tacoma. Obviously there's a crumple zone in the front for engines, but most engine compartments are meant to basically, once they get to a certain point, fall on the ground. And so that's why you'll see a lot of people, and then when it falls on the ground, it brings the dash with it. And so that's why you'll see a lot of patients with broken legs. It's because of that, it's meant to do that. It's meant to try to not get into the passenger compartment. And so you'll see a lot of patients with, broken ankles, broken legs, anything from the waist down because of that dash coming down. And that happens all the time. And so you can see that this is attributing to why it takes so long for you guys to get traumas. So calls like these happen probably 3 or 4 times a week within the city of San Diego. So maybe even more on average. So you can see that this extrication to get this patient out is going to take about maybe an hour to get her just out of that front seat. And then once we get her out, then we have to C-spine her. We have to start an IV. We have to, most of the time you guys, there's a lot of resources at the scene, so you guys are going to get another medic making the initial notification. So you guys may get an initial notification literally an hour before you guys even get the patient. But that's on the MICN. Some MICNs don't say, they just say, hey, give us a heads up when you're 10 minutes out, and then I'll let you guys know. Sometimes that happens, sometimes we forget, that happens. So without going into the whole anatomy of what exactly we do on scene, you can see that there's a lot going on there. So real quick, I'll go through our initial radio report for this lady. So a radio report they're long, they're very detailed. Sometimes that information doesn't get across to you guys because they just want the pertinent stuff, but this is on typical radio report for us. So UCSD, this is engine 29. I have a 140-pound, 25-year-old female who was involved in a traffic accident, single vehicle traffic accident. She was a restrained driver. She slammed into a pole going approximately 45 miles per hour. And then we go into basically what we find. So right now she's breathing at 24 strong and effective. Her response is ×4, which is person, place, time, and event. Her motor is ×4 with the exception of her right foot is pinned underneath the dash in some way, somehow. So her chief complaint though, however, is chest pain. So why would she be having chest pain? Airbag. Yeah, airbag, steering wheel. There's a lot of, and people, Stephanie was like, well, if she's got her right foot pinned, how come she's not complaining of right foot pain? She's not going, if her chest is the one thing that's hurting the most, that's what she's going to complain about. She probably has no idea that her foot is either broken or whatever the case may be. So here's some of the vitals, the pertinent vital signs that we'll give over the radio. Pretty self-explanatory. So as far as treatment is concerned, okay, like I said earlier, ABCs are so important, so important. And I know it's technically not a treatment, but because this is the staple that we use, we're constantly reassessing. So on a patient like that, she may be fine. She may get out, she may be able to walk, her foot may be fine, but we're constantly assessing ABCs en route to the hospital. So that's a huge part of our treatment. Our next portion of treatment is going to be C-spine. So most of those patients in traffic accidents like that are going to get C-spine. O2, IV if necessary, and a fluid bolus. So we only give fluid boluses now. It used to be 10 years ago, that patient would get C-spine, IV, monitor, O2, 2 large bore IVs, and run straight to the hospital. And nowadays that will not happen. She may come in with just a saline lock and they call it a day. If her lungs or BP is above 80, they may not even give her an IV. So yeah, so it happens. Stephanie had just, how many of you guys are familiar with how we get patients out of cars and C-spine? Anybody? No? This is, how many people are familiar with how C-spining patients in and out of cars? So this is a part of the other process of getting patients out. This is why extrication takes so long. So you can see here in the back seat, this is a driver, someone's in the back seat holding C-spine while someone puts a collar on them, while other people are trying to figure out how to get them physically out of the car. Whether that's pulling them out from the front passenger seat, pulling them out of their driver's seat, taking off the roof of the car just so we can get them out. It just depends. And so while we're doing that, obviously we have to maintain C-spine. So there's usually somebody back there with, holding manual stabilization the whole time while we're getting the patient out. So it takes a lot of people and it takes a lot of resources to do that. So that's another contributing factor why sometimes it takes a long time to get your patients to you guys. So, and that's gonna be the end of it. That's all I got for you. So the end goal is we want to package up these patients and get them to you guys as fast as possible. That's the goal. Sometimes it may not come across, but that's what we want to do. Is we want you guys are taking care of them for a long term. We see these patients on average of about 15 minutes per call, and so you guys see them for a lot longer, and you guys are taking care of them for a lot longer. So that's our goal: is package them up, treat what we can treat at the scene, and en route, but get them to you guys. So that's it.